Good evening. I would like to welcome the Board of Directors, members, key personnel, and staff of the Bill and Melinda Gates Foundation. My name is Saria Boditella, and I am a public health nurse. The purpose of our meeting today is to deepen our understanding of the state of maternal and child health in Afghanistan, with special attention to maternal mortality through topic highlights, contributing causes and factors, and proposed interventions. The current maternal mortality ratio in Afghanistan is approximately 400 deaths per 100,000 live births, compared to the global average of 216. Afghan mothers and children's mortality rates remain among the highest in the region due to various factors affecting the healthcare's capacity to reduce the risks that pregnant women face. Pregnancy-related causes remain the leading risk of death for women in their childbearing years. Hemorrhage is by far the leading cause of maternal deaths, followed by eclampsia, obstructed labor, and sepsis and infections. Women with unintended pregnancies that are continued to term are more likely to receive inadequate or delayed prenatal care and have poorer health outcomes than women with planned pregnancies. Due to the lack of family planning, women are generally giving birth frequently, disallowing their bodies to fully heal from their previous pregnancies. Approximately 50% of Afghan girls under the age of 16 are married, and 70% of all Afghan marriages are forced. Care from the opposite sex is frowned upon, yet the number of female doctors and midwives are low due to the discouragement of female education. Being a low-income country recovering from decades of war and violence, with an ineffective government under the Taliban regime, caused the healthcare system to become disarray. Primary healthcare delivery has been mainly through non-governmental organizations. During the regime, women were prohibited from going to school, thus no female doctors or nurses were trained during this period. There are 6,000 physicians and 14,000 nurses for a population of 28 million. Due to poor infrastructure and the geographical location of Afghanistan, it can be difficult transporting women to hospitals. Many people do not own cars and rely on motorbikes and donkeys as primary modes of transportation. Based on the information gathered, we can confidently define the MCH issue of maternal mortality in Afghanistan, as Afghan women and young girls do not have access to quality health care due to weak public health provisions and strict conservative barriers. Here, we apply the social ecological model to the MCH issue, highlighting factors that help the promotion of health and factors that hinder the promotion of health. We will first examine the individual level. Although women employment rates are steadily increasing in Afghanistan, it is the cultural norm, the aftermath of a corrupt government, and decades of combat that women essentially do not work or attend school. Educated Afghan women who have high literacy levels are more willing to engage in positive pregnancy behaviors. Many Afghan women choose not to receive cesarean sections because it is considered to be a medical intervention, which is regarded with some suspicion. Only 1.1% of all births in 2009 were a result of a cesarean section. At the interpersonal level, we have village leaders and traditional birth assistants in the community who are willing and able to assist in childbirth. Although this method is not preferred, if women are not able to reach hospitals, they are able to turn to these members of the community for care. In a country governed by strict religious and cultural practices, many women are unable to seek routine healthcare services and emergency assistance because a male is unavailable to accompany them outside of their home, resulting in an increased number of at-home births without the necessary healthcare professionals administering the delivery. We will now examine the organizational level. With strict cultural values, men prefer that their wives and daughters receive care from women. Therefore, the need of women healthcare professionals is critical to decrease the maternal mortality rate. The advantages of many midwifery education programs are that it selects students from the community and redeploys them to the same community upon graduation. Midwifery programs also offer an entry point for girls and women to obtain an education, earn an income, contribute to their communities, and enhance their mobility, which all are indirect factors that improve maternal health. Next, we have the community level. With majority of healthcare funding stemming from outside sources, public awareness and advocacy is crucial to the female population of Afghanistan. 80% of the Afghan population cites healthcare as one of the top 5 biggest problems facing their communities and is one of the only touching points that Afghan citizens have with their government. Transportation in Afghanistan is limited and still in the developing stage. Transportation facilitates the timely delivery of basic health and reproductive services while enabling people to access services and healthcare workers to reach communities in rural areas. For the final ban policy, the private health sector is often viewed as a critical component to expand health services and achieve governmental health goals. In 2008, the Afghanistan Ministry of Public Health began to adopt strategies, policies, and regulations aimed at harnessing the for-profit health sector. As a result of this well-executed program, the country's basic health indicators improved significantly, yet at the same time the private health sector became largely unregulated at a rapid pace. Postpartum hemorrhage is the leading cause of maternal death in Afghanistan. Misoprostol is an uterotonic drug that is growing popular in the developing world due to its low cost and heat stability. It can be taken as a pill and administered without an injection or a skilled birth attendant. Maternity waiting homes are facilities that are within easy reach of a hospital or health center. Women with high-risk pregnancies or those who live remotely are encouraged to stay at these facilities toward the end of their pregnancy. When labor is induced, women are quickly transported to the nearest hospital or health center for delivery. Educational programs have the potential to produce changes in primary knowledge and information of pregnancy and deliveries and enhance capabilities, which could produce reductions in maternal mortality. Mothers, traditional birth attendants, community leaders, and relatives will be urged to attend educational programs in their communities where they receive training in prenatal, natal, and postnatal care. Community health assessments and reporting programs will be vital tools in order to evaluate the success of the interventions. In addition to reaching their intended goals, interventions will be evaluated based on if there is a decrease in maternal mortality rate, PPH diagnosis, pregnancy and delivery complications, increase in community access to hospitals and health centers, if there's collaboration between educational programs and teaching centers, and specific needs identified among communities integrated into the curriculum. In order to measure the success of the proposed interventions, the number of PPH prescriptions, pregnancy delivery complications, and hospital admittance rates will be compared to the rates gathered before the implementation of the interventions. We would like to see an increase of PPH medications prescribed and utilized by 50%, a decrease in pregnancy and delivery complications by 50%, and an increase in hospital admittance for childbirth by 30%. We will measure the knowledge of prenatal, natal, and postnatal care among participants in the third intervention involving the educational programs through assessments and follow-up observations in their respective communities. In a society where the way of living is heavily influenced by culture and religion, the implementation of new interventions may face challenges such as refusing to take certain medications or the discouragement of female education. Individuals' knowledge, attitudes, and health beliefs are difficult to alter or change because the behaviors associated with individual thinking takes place in social environments that encourage the established beliefs. Cultural adaptation involved a planned, organized, and collaborative process that often includes the participation of persons from the targeted population for whom the adaptation is being developed for. Foregoing meaningful relationships with community leaders and public health officials will allow trust to be built between healthcare professionals and the communities they serve and ease the promotion of changing current health behaviors and practices. For example, the intervention involving maternity waiting rooms should be fully equipped with areas for supervision of children and culturally appropriate rooms to accommodate husbands and family members. Lack of literacy and education among women in Afghanistan poses a huge challenge when aiming to implement the proposed interventions. Unfamiliarity with common health language, reading, and writing creates room for misunderstanding and decreased motivation to learn. For the intervention involving educational programs, it should take into consideration the literacy and existing education level of students and simplify educational materials. I have provided a logic model to present and share the relationships among the resources to operate the programs, activities, and the changes or results we hope to achieve. In the inputs column, we have the resources needed to implement the 3 interventions. In the activities column, we have the actions that we will be used to achieve the intended results. In the outputs column, we have the direct results of the intervention activities. In the outcomes columns, we have the changes that occur between the inputs and the outputs. These are the immediate changes that may occur in participants. The impact is the longer term or systematic change that will occur as a result. This concludes the presentation. Thank you for your time.